Hi, my name is Anthony Wick, and I am a future nurse practitioner. Today, I am going to be performing a respiratory assessment for the course graduation requirements of my health assessment class. This assessment is going to involve inspection, palpation, percussion, and finally, auscultation. So here again is the presenting patient, Mr. Perez, and this is a healthy 32-year-old Hispanic male who has presented to the office with no chief concerns or complaints today. Now, before my arrival, I would have had my assistant already perform a vital sign check on Mr. Perez, and so I would say his blood pressure would be about 114 over 73. His heart rate would be 90, his temperature 36.9, and his oxygen saturation 100%. His height would be 5'8", and his weight is approximately 154 pounds. Now, because we're doing a focused respiratory assessment, I would start by asking Mr. Perez if he's had any generalized pain, any cough, any chest pain, any shortness of breath recently. Excellent. And so from our last meeting, I had noted in the previous video that you had asthma. And you were taking albuterol. Has that been holding up for you?
Yep.
All right. And is it still providing adequate relief when you're using it?
Yes.
How often are you using it?
Every so often. Once a month.
Once a month. And when does it expire?
Next year.
Perfect. And then again, I just want to confirm from our last meeting that you don't smoke or use any illicit substances.
No.
Okay. And have you traveled outside of the United States recently?
No.
Excellent. So then, for this examination, the respiratory exam, I'm going to ask Mr. Perez to just sit up straight, upright, with his arms at his side or in his lap, whichever's more comfortable. And because this is a male, now in the office, I would ask him to disrobe at the waist, and for females, I would leave the gown open in the back, just to kind of ensure their privacy. But in this case, and since it's being filmed on YouTube, we're going to have Mr. Perez leave his shirt on, and we're going to just perform the assessment with his shirt on. So first, I'm going to begin with inspection, and I'm going to inspect the thorax, the anterior and posterior chest, and I'm going to be looking for deformities or asymmetry. Now, throughout the entire exam, I would be visualizing the patient's respiratory pattern and rate. However, I wouldn't normally make this known in an office visit, just because it may change their baseline respiratory rate or depth just subconsciously without them even thinking about it. So again, throughout this whole assessment, I'm inspecting for abnormalities, and that could be like accessory muscle use, rapid breathing, giant strokes, respirations, chest retractions, decreased breathing, or diaphragmatic breathing. Again, these are all would be like marked symptoms of respiratory distress. Okay, so first I would begin inspecting the skin, and I would be checking to see if there are any lesions or marks, lacerations, or masses that would be visibly present. So let me start with that, and I'm just going to be looking around the chest. I'm noticing some hair here on the anterior chest. Again, the back has no markings or deformities. All right, so, well, with inspection, I analyzed the skin color, and that appears appropriate for Mr. Perez's ethnicity. And I don't see any pallor or cyanosis present, which could also be indicative of respiratory distress. Now, from the posterior side, I had noticed that his scapulas were symmetrically aligned, and I also observed that the muscles in his neck appear normal. And I was also able to see a bit of the curvature of the spine, and I assessed that it was straight, so there's no kyphosis or scoliosis present. And then from the anterior view, besides the chest hair that I had mentioned, I also saw that his chest was symmetric. The thorax appeared symmetric as well. And then from the AP ratio, which is the anterior posterior diameter, it was less than a transverse, and that's normal. It should normally be like a 1-to-2 ratio. And now, if I had seen that the neck muscles were hypertrophied, or I noticed what is known as a barrel chest, or even if I saw the patient sitting in sort of a tripod positioning with his arms braced, I might suspect that this patient would be suffering from something like COPD. So next I'm going to begin palpation, which is the portion of the exam, and I'm going to begin on the posterior chest. And here I'm just going to be checking for equilateral chest expansion, tactile fremitus, or any tenderness the patient reports. Actually, maybe it would be better if you turn for me. So to begin with palpation, first I want to assess that that there's equilateral chest expansion. All right, so I'm going to begin by placing my hands just on the, it's really hard to do this with the camera, but the post-lateral chest here at the level of like the T9 or T10, and then ask Mr. Perez to take a deep breath and let out. All right, and you did that through your mouth, which is excellent. And I should notice that my thumbs moved apart symmetrically, which they did. And now, had his chest not moved symmetrically with the palpation, I might consider the patient to be suffering from something like pneumonia or thoracic trauma or even atelectasis. But next I'm going to palpate for tactile fremitus or vibrations. And I'm going to be using my finger pads over all areas of the lung. And I'm going to ask Mr. Perez to say 99 each time that I change positions. So
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Excellent. So in this assessment, I noticed that there was no decreased fremitus in any of the areas that I had palpated. And if there had been decreased vibrations felt, then I would have thought about maybe an obstruction due to these decreased transmissions. And this can occur in cases also like COPD or even something like a pneumothorax. And then I want to just check with Mr. Perez that during that there was no tenderness in any of the areas.
No.
All right, perfect. So then I'm going to be moving on to percussing the posterior chest, which is the act of tapping between the interspaces of the rib cage just to assess the structures that would lie beneath the skin. Now I'm going to be performing this assessment as I did the last one in a systematic manner from the upper chest to the lower ribs, and then from the left and the right sides for equal comparisons. Now I'm going to be using my non-dominant hand, which here is my left hand, and I'm going to be using my middle finger here. And that I'm going to have hyperextended, and it's just going to be pressed on the area. And then I'm going to use my dominant hand's middle finger to tap right underneath my nail here. And I'm going to be listening for a resonant sound in all of the lung fields. So just Excellent. So I heard resonance throughout all the lung fields. Now, however, had I heard something else, I might suspect an obstruction, something like a mass, or maybe a tumor, or possibly I could have just been over bone. However, I might also be thinking of pneumonia or atelectasis, which could produce more of a dull sound instead of the resonant sound which I heard. If I had heard hyperresonance, I would know that there's too much air present in the lung, and so I'd be concerned with something like emphysema. And tympany, I might consider pneumothorax. So then moving on with percussion, I want to assess the diaphragmatic excursion of this patient. And I'm gonna actually percuss to map out the lower lung border, and during both inspiration and expiration. And then I'm gonna measure the difference, and I'm gonna use this card here to measure the difference, and I'm just gonna kind of pinch up on his shirt. Now I'm gonna ask Mr. Perez to take a deep breath in and then hold it, and I'm gonna be noting where there's no more air. And then I'm going to make note of it. And that is going to be his inspiratory marking, which is the lower one. I'm just going to straighten out your shirt here. All right, if you could just take a deep breath in and hold it. All right, so this here is the marking here. You can breathe out. Thanks. All right. And then I'm just going to ask him to breathe out and then also hold that as well. And that's going to be his expiratory marking. So Mr. Perez. And just hold it, hold it. Okay. It's really difficult for the camera to see, but it appears, if I use my card, it would appear approximately, I would say about 3, maybe 4 centimeters. So now I'm also going to do it on this side here. And Mr. Perez, can you take a deep breath in and hold it? This side, sorry. You can take a deep breath in and hold it. Again, I'm just noting where it goes from resonant to dull. And that's right here, exactly where the other one was. And breathe out, I'm sorry. And then I'm gonna have you exhale and hold it. And again, I'm just noting where it would go. And that's actually exactly where the other one was. And again, I would measure this side, and again about 3 to 4 centimeters. And they're equal bilaterally, and all of this is normal. So thank you for doing that. Now, if this was not normal, I would think of maybe something like a pleural effusion or atelectasis. But again, anywhere between 3 to 5 centimeters in a normal in an adult is normal, and I would roughly estimate that his was about 4. So then finally, for the posterior lung assessment, I'm just going to be moving on to auscultation, and that's where I'm going to be listening to all of his lung fields. And again, I'm doing this in a systematic manner, from the upper chest to the lower chest and from left to right, just so I can get a good idea of equal comparison. I'm going to ask Mr. Perez to again be taking these deep breaths through his mouth, and I'm going to be listening for any signs of, well, there's 3 sounds that I should be hearing. One should be bronchial, and the other should be vesicular, and the other should be bronchiovesicular. Now, the bronchial sounds are heard in the upper portions of the lung field, and that's near the trachea and the larynx, and those are going to be both high and loud. Bronchovesicular sounds are heard more over the major bronchi, and they're moderate in pitch. And then the vesicular breath sounds are going to be heard in the peripheral lung fields, and they're going to be low and soft. Again, I want to make sure that I'm going in between each intercostal space so that I can get the best sound possible. And I'm using my diaphragm of my stethoscope to hear these lung sounds. And I'm listening in each field, for each low breath, or with one full breath, I'm sorry. So I'm gonna be performing that now. Excellent. 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 Thank you. So I heard all of the breath sounds in their appropriate locations, the bronchial breath sounds, bronchiovesicular breath sounds, and then the vesicular breath sounds. There was no decreased or absent breath sounds, and that would be caused by something like an obstruction or maybe a mass, like with air or fluid. And then there were no adventitious sounds, which were crackles, wheezes, or stridor. And those could be indicative of something like pneumonia or asthma or an obstruction, respectively. So that concludes the posterior portion. Now I've inspected, I've palpated, I've percussed, and I've auscultated. And now I'm going to be moving on to the the anterior portion of the chest, the front. And now, since I've already performed my inspection in the initial part of this video, I'm going to begin with palpation. So again, I'm going to test the patient here for tactile fremitus. And Mr. Perez, can you please say the phrase 99 for me after each time that I change positions?
99. 99. 99. 99. 99. 99. 99. 99.
Excellent, thank you. Now again, I noticed here normal vibrations, and there was no decreased fremitus in any of the areas. Next, I'm going to again be percussing for diaphragmatic excursion. So Mr. Perez, I'm just going to ask that you take a deep breath and hold it for me. And I'm going to be noting where the sounds again go from that resonant to dullness. And the dullness would be where there's no more air. So here we go. Just take a deep breath for me and hold it. So that's one. Let go, please. Thank you. Just making a pinch mark here. All right, and now I'm going to ask that you exhale through your mouth perfectly, and I'm going to So that was the old one. And again, it's between 3 and 5 centimeters. Let me check this side. Mr. Perez, can you Again, breathe all the way out and hold it for me. All right, just pinch the shirt up here a little bit. Now again, normally you would make markings, but because I'm not exposing his skin, I am choosing to do it with the shirt. All right, Mr. Perez, can you breathe all the way out for me? And hold it. That one, and that one. And again, it would be about, between those two, about 3 to 5. Then the last part of this exam would be the auscultation again. So again, I'm gonna be listening for all 3 sounds, the bronchial, the bronchiovesicular, and the vesicular breath sounds, and noting that they're in their appropriate locations, and noticing if I hear any adventitious breath sounds, which I shouldn't be hearing. Breathe in through your mouth. And out. Excellent. Okay, so again, I heard all of the breath sounds in their appropriate locations. And again, there was no decreased or absent breath sounds, no adventitious sounds. So then I can conclude after, now that I've done my inspection, palpation, my percussion, and my auscultation, I can conclude this respiratory assessment. And Mr. Perez, do you have any questions for me?
No.
All right, thank you so much, and I look forward to seeing you in our cardiac assessment.
Thank you.